Hello everyone and welcome to today's high-yield digital revision. आज हम cover करने वाले हैं एक massive 5-star topic, Pregnancy Induced Hypertension, यानी PIH. अगर आप exams या OBGYN clinical words के लिए prepare कर रहे हैं, तो भाई ध्यान से सुनो. हम अपने fundas एकदम crystal clear करेंगे so you can tackle absolutely any clinical scenario or direct NCQ. Chalo, let's dive right in. So here's our roadmap for this explainer. First, workup and patient triage. Second, timing of delivery guide. Third, severe PE and eclampsia. Fourth, antihypertensive drug protocols. And finally, fifth, magnesium sulfate regimens. Section 1. Workup and patient triage. First steps at admission. Picture this. A pregnant female casualty mein aati hai with elevated BP. So, what's your immediate next step? You need to categorize her fast. To do that properly, we need proper history and these mandatory lab tests right off the bat. We're talking liver function tests, serum creatinine, platelet count, and LDH. But hey, focus specifically on the peripheral blood smear here. You are actively looking for schistocytes, you know, those fragmented red blood cells. Kyun because ye ek direct exam pearl hai guys. Our absolute main goal here is to rule out HELP syndrome, jo ki ek super severe complication is.
Okay, once the reports are in, you triage. The magic cutoff number you absolutely must remember is 160 by 110 millimeters of mercury. Agar BP 160 by 110 ke niche hai, and there are absolutely zero signs of end organ damage, well, that's mild preeclampsia. You can safely manage that on an OPD basis. But agar BP crosses 160 by 110 or koi bhi end organ damage dikhta hai, boom, it automatically becomes severe preeclampsia. That means mandatory inpatient admission. Isme literally koi compromise nahi.
Moving on to Section 2, Timing of Delivery Guide, When to Terminate. Diagnose the kar liya, but how do we actually cure her? Remember the absolute golden rule of PIH. The only definitive management, the ultimate cure, is the termination of pregnancy. But timing is everything. Let's break it down. For mild preeclampsia, target 37 weeks. For severe preeclampsia, the target shifts to 34 weeks. Chronic hypertension alone goes to 37 to 38 weeks, but if it has superimposed preeclampsia, you terminate at 37 weeks. Now listen to me very carefully here. Eclampsia, HELP syndrome, and placental abruption, these are absolute dire emergencies. Yahan ek hi rule hai. Immediate termination of pregnancy irrespective of gestational age. Aap wait nahi karte, you stabilize and deliver. Now, maternal condition is only half the picture, right? Fatal monitoring is highly critical too. Notice these umbilical artery Doppler findings that literally always show up in your MCQs. An SD ratio greater than or equal to 3 means you deliver at 37 weeks. If you see absent end diastolic flow, things are definitely getting worse. Terminate at 33 to 34 weeks. And the absolute most dangerous finding, reversed end diastolic flow. That requires termination at 31 to 32 weeks. Keep these objective markers locked in your memory for sure.
All right. Section 3. Severe PE and eclampsia. The emergency room. The patient is admitted. Severity बढ़ रही है. Now we're in the ER dealing with impending disasters. Convulsions आने से पहले, the patient actually gives warning signs. इसको बोलते हैं impending eclampsia. The classic triad includes visual disturbances, severe headache, जो कि about 70% cases में होता है, and epigastric pain. Now, epigastric pain क्यों होता है? It's because of a subcapsular hematoma, literally stretching the liver capsule. Ward में अगर ये दिखे, तो act immediately because a seizure is definitely coming. And if that convulsion does happen, here is your exact step-by-step management algorithm. Step 1. Syringe के पीछे मत भागो. First, protect your patient. Raise the bed rails and manage that airway. Step 2. Administer magnesium sulfate to treat and actually stop those convulsions. Step 3. Give intravenous antihypertensive drugs to bring the blood pressure down. And finally, step 4, definitive management, which is immediate termination of pregnancy. This specific sequence is literally your life-saving protocol.
Section 4, Antihypertensive drug protocols, controlling the crisis. Getting that blood pressure safely under control is absolutely crucial. So let's dive right into the pharmacology. Our target here is not a normal 120 by 80. No way. The target BP is actually 130 to 140 systolic and 80 to 90 diastolic. Our safe first-line drugs are labetalol, hydralazine, and nifedipine. And please notice this very carefully. Nifedipine must be oral, not sublingual. Galti se bhi sublingual mat dena. And mark my words here, avoid overcorrection. Agar BP achanak drop hua,
यूट्रोप्लेसेंटल परफ्यूजन ऑटोमेटिकली डिक्रीज होगा, which will cause acute fetal distress.
For a true hypertensive crisis, IV labetalol is our absolute champion. Dose goes systematically escalate karo, so give 20 milligrams IV, wait 15 minutes and check the BP. If it's still high, push 40 milligrams IV, wait 15 minutes. Still high, push 80 milligrams IV, wait another 15 minutes. You can do one last push of 80 milligrams IV. The absolute maximum total dose you can give is 220 milligrams. This stepwise approach is exactly how you safely manage the crisis, right there on the word.
Now, क्या देना है उससे ज़्यादा important है क्या नहीं देना है. These are absolutely contraindicated. ACE inhibitors, ARBs like losartan, all other beta blockers except our good friend labetalol, and diazoxide. And look at diuretics, strictly contraindicated in preeclampsia. क्यों? Because P is already a state of severe hemoconcentration. Diuretic दोगे तो intravascular volume और भी ज़्यादा deplete होगा, which is just a massive disaster.
Section 5. Magnesium sulfate regimens, the magic bullet. Obstetrics का absolute VIP. Magnesium sulfate. ये central nervous system पे act करके उन eclamptic seizures को रोकता है.
You really need to memorize two main regimens here. The Pritchard regimen, Indian words में यही चलता है. It utilizes an intramuscular approach. The loading dose is huge, 10 grams IM, that's 5 grams in each buttock, plus 4 grams IV. The maintenance is then 5 grams IM every 4 hours. On the flip side, the Zeuspan or Sabai regimen is what ACOG recommends, and it is entirely intravenous. You give a 4 to 6 gram IV loading dose over 15 to 20 minutes, followed by a continuous IV infusion of 1 to 2 grams per hour.
Magnesium sulfate has a very narrow therapeutic range. Toxicity का खतरा हमेशा रहता है, guys. So before you give that next maintenance dose, you absolutely must perform these 3 mandatory clinical checks like a super strict examiner. Number 1, deep tendon reflex or knee jerk must be present. Number 2, respiratory rate must be greater than or equal to 12 per minute. Number 3, urine output must be at least 100 cc over the last 4 hours. All 3 criteria must be positive. It be missing ho? You absolutely withhold that dose. Which brings me to a direct question for you all to really test your fundas. You are actively monitoring a patient on the MgSO4 infusion. So, what is the very first sign of toxicity you must look for on the wards? Thoda dimag lagao.
Well, if you said loss of knee jerk, you are absolutely correct. At 9 to 10 milliequivalents per liter, the knee jerk just disappears. ये आपका first warning sign है. At 12, respiratory depression starts, leading to arrest. At 15, cardiac arrhythmias begin. And at 24, cardiac arrest occurs. Also, definitely note this clinical pearl. Oliguria is a reason for toxicity because the drug is excreted by the kidney, but oliguria itself is not a sign of toxicity. Agar toxicity hit kare, immediately push your antidote, 10 ml of 10% calcium gluconate IV.
And that wraps up our highly focused digital revision on PIH management. We've covered triage, delivery timing, eclampsia steps, pharmacology, and the complete MgSO4 protocol. Keep your basics strong, master these exact steps, because in real life, applying these perfectly literally means you save 2 lives at once. So the next time you are on ward duty and a patient seizes, will you freeze or will you be totally ready to execute the protocol flawlessly?